At this time, I'll turn the podium over to Dr. McGregor, who is the study chair for SWOG 1207, which is the phase 3 randomized placebo-controlled clinical trial evaluating the use of adjuvant endocrine therapy plus or minus 1 year of everolimus in patients with high-risk hormone receptor positive and HER2 negative breast cancer.
Hi, good morning, everybody. I want to start by thanking the organizing committee for allowing me to be here this morning. This is really a unique opportunity for us to come and talk to you about our trial. And not only I want to explain you a little bit about the background of the study and why we're so excited about it and why we think it can make a huge impact to our breast cancer patients, but also want to really acknowledge some challenges that we've faced since we activated the study and how we're taking into account your feedback to try to make this trial easier, more accessible for all our patients. So just a little bit of background. Breast cancer, as you all know, it's the most common cancer in women. And even if we've tried and make incredible progress with new drugs to improve the outcomes of our patients, the truth is that as of today, metastatic breast cancer continues to be an incurable disease. Therefore, it's very important for us to keep moving our field forward and try to avoid for many of our patients to develop metastatic disease. In the metastatic setting for patients with hormone receptor positive breast cancer, the main therapy that we have is endocrine treatments. So with medications like aromatase inhibitors, tamoxifen, fulvestrant, we have able to really offer a lot of options to our patients. But the truth is, and if I can find the, here it is. The arrow, we know that as we move forward for first, second, third, or fourth line, our patients develop resistance. So this is a clear phenomenon for patients with hormone receptor positive breast cancer. And the mechanism to understand this resistance, it's actually quite complex and take us back to, a lot of different pathways. One of them, the PA3 kinase, AKT pathway, that actually interact with the estrogen receptor and determine or led to this endocrine therapy resistance. So endocrine resistance, it's a challenge, and for us in the oncology community, it's something that we're trying to overcome. The Bolero-2 study was a large randomized phase 3 clinical trial in the metastatic setting in which postmenopausal patients that have been previously treated with letrozole or anastrozole were randomized to receive exemestane with placebo or exemestane in combination with everolimus. Everolimus, it's an oral drug, it's an mTOR inhibitor that it blocks that PI3 kinase pathway. Therefore, we believe that restores the endocrine sensitivity. So in this study, what we observed was that patients that received the combination with the exemestane and everolimus had a much higher rate of clinical benefit. There were more responses. And more importantly, the time to progression was significantly delayed. So as you can see in the red line, patients that receive everolimus in combination of exemestane had a time to progression of about 8 months compared to patients in the exemestane and placebo arm of only about 3 months. And this is, like a huge difference. The data on overall survival was just recently updated and presented at a meeting in England last month. And seems that there's no impact in overall survival, but having said that, this study led to the approval of the drug in the metastatic setting. The drug has shown to benefit all patients regardless previous chemotherapy, progesterone status, or even visceral disease. And it is true that the drug has some side effects. It doesn't have the side effects that we usually see with chemotherapy, so in that regard has a much more favorable toxicity profile. But some of the things that we see quite often are fatigue, stomatitis that usually presents in the first 4 weeks of therapy, problems with hyperglycemia and abnormalities in the lipid panel, and very rare, but things that we need to know, problems with pneumonitis. So I want to emphasize the data of Bolero because this is the platform that we use to propose S1207. And everolimus, it's really the first drug that it's significantly enhancing hormonal therapy and reverting this endocrine therapy resistance. Think about the patients that were enrolled in this study. There were patients that progressed on aromatase inhibitors, and then we're giving them a new aromatase inhibitor plus something else. So this new drug, it's just making the endocrine therapy work a little better. So based on this, we propose S1207, which is a very ambitious phase 3 randomized placebo-controlled clinical trial in which we're trying to determine if adding 1 year of everolimus to adjuvant standard therapy would improve the outcome of our patients. Are we going to be able to cure more patients with breast cancer by adding this drug and avoid for them to develop metastatic disease? Because as I said at the beginning, that's one of our big challenges. So of course, we're not only going to look at disease-free survival, we're going to look at overall survival, safety, toxicities, quality of life, and this study has built in tissue collection that it's going to allow us for some incredible science and some biomarker studies. So this study, we are launching SWOG. It's the main group, but some of our colleagues at NSABP are an important part of it. It's a very simple study, and it's designed because it's a parallel randomization with, a 1:1 randomization. This is the big schema. So patients with breast cancer go on to receive the standard treatment that, your teams are providing. Patients receive chemotherapy. All patients need to receive chemotherapy because, again, remember, we're trying to target those very high-risk patients, the patients that are really high risk of developing metastatic disease. So patients receive chemotherapy, whether in the neoadjuvant or in the adjuvant setting. They, of course, go through surgery and radiation therapy if indicated. And it's once all their treatment has been completed that patients get randomized to receive endocrine therapy, selection of the treating physician, plus everolimus or placebo. These are some of the key eligibility criteria. Patients need to have hormone receptor positive, HER2 negative breast cancer that are going to receive endocrine therapy. Patients must have completed chemotherapy within the past 21 weeks. So there's patients that maybe completed therapy like 2-3 months ago that are still eligible. And when patients receive radiation therapy, we want to wait a little bit, around 3 weeks, until the toxicities are resolved, our patients are feeling better. Something very important is that patients could have started receiving endocrine therapy before. So there's some sites that maybe like to give endocrine therapy in combination or simultaneously with the radiation therapy. So even if that patient already started on tamoxifen or in an anastrozole few months ago, that patient, if it's still within that 21-week window from the last dose of chemotherapy, it's still eligible. Now, the part that gets a little complicated that has caused some communication between you and some of us, it's the high-risk groups that we're targeting. So patients can be node-negative with tumors greater than 2 centimeters that per standard of care get oncotype and have a high risk. So only those patients with oncotype that is high and node-negative are eligible. And this is standard of care, so therefore we're not providing coverage for the oncotype. For patients with 1 to 3 positive lymph nodes, we're only allowing enrollment of those with recurrence scores of greater than 25 that have completed chemotherapy. Now, in this group of patients with no positive disease, it's not common practice for oncologists to order oncotype. So what we were thinking when we designed the study is that some of you may have responder open in your centers, that it's S1207. So it's those patients that get screened for responder, and responder only allows low recurrence scores. So therefore, the ones that are not enrolled in responder could be screened for our study, and we'll be back at this at the end. Patients with 4 or more positive lymph nodes, everybody's eligible regardless oncotype. And those patients that receive neoadjuvant chemotherapy and have a lot of residual disease, meaning 4 or more positive lymph nodes at the time of surgery, are also eligible. So as I said, patients get randomized to receive everolimus or matched placebo. The pills come in 5 milligram tablets, so therefore patients have to receive 2 pills. And as I said, this is a very ambitious study, and we really appreciate all your help in recruiting. We're planning to randomize 3,500 patients. So as you know, in the adjuvant setting, for us to really be able to see a difference, we have to enroll a lot of patients. So we're going to need your help throughout the years to make this trial a success. This is a schema of how we navigate through patients going through surgery. Those that are no negative go through recurrence score, and only those that have the high recurrence score are eligible. Similar to those 1 to 3 positive nodes, they have to get oncotype. Those that have 4 or more don't need to consider oncotype. All of them get adjuvant chemotherapy, radiation therapy, and then randomized. And as I said, those that go through neoadjuvant chemotherapy up front have to have a large number of residual disease in order to be eligible. So as I said, responder and our study are mutually exclusive. They both include patients with 1 to 3 positive lymph nodes, but responder takes the low-risk patients, and we're taking the high-risk patients. So I invite you to please keep in mind our study when you are screening patients for S1207. So this is study calendar, and of course you'll have access to it. But there's some concerns from some of the investigators regarding toxicity. The first 6 weeks, there's telephone interviews to evaluate toxicity. I have a lot of experience with the drug in the metastatic setting, and we're trying to provide a lot of information for our investigators so they can feel comfortable managing the drug. So as I said, there's a lot of translational studies and a lot of science that we're going to be able to obtain with this study. Blood, it's mandatory. Tissue, it's mandatory if available. And something that it's unique about this study is that we have included obtaining tissue at the time of recurrence. So therefore, we're going to be able to learn a lot of those tumors that came with the tumor recurred and compare it with the initial primary tumor. There is a component of quality of life that it's under the leadership of our colleagues at NSABP, that it's only available as CCOPs. This component is going to enroll close to 500 patients, and the big difference is that in order to enroll in the quality of life study, patients should not start endocrine therapy until they register. Remember that initially I said that for the big study, patients could have started before. For the quality of life study, because they want to see how the new drug interacts with the aromatase inhibitors and the endocrine therapy, they have to be started at the same time. So as excited as we are about the study, this is the Accrual. So this is our goal at the top in red. So even, I know that some studies are just getting IRB approved, but since we activated at the beginning of September, we have not seen the Accrual pick up, and we actually have gotten a lot of feedback from you. I'm sure, I've exchanged emails with a number of you sitting here in the room, and some of the feedback that we've received is the patients that receive neoadjuvant chemotherapy, maybe there's patients that have 3 positive lymph nodes or 2 positive lymph nodes and a huge primary tumor. Why to really require those 4? Similar, feedback we've gotten about why we need to get the oncotype in those that are 1 to 3 positive lymph nodes, because, many of your patients may have a very high-risk patient. It's a young woman. They're not even considered responder or may not have responder. It's a high-risk patient that it's going to receive chemotherapy, and no insurance, it's going to take on the cost of oncotype after the patient already received chemotherapy. So this has been like 2 persistent concerns that we've heard from you. And of course, we have other issues that we're improving regarding concomitant medications and all. So the truth is that we're taking your feedback into account, and actually serious changes are gonna occur in the near future. So as of today, the study is as I presented to you, but be aware that we're gonna be working on expand our eligibility criteria, and what we're discussing our breast committee meeting later today is that we are going to allow patients with neoadjuvant chemotherapy that have 1 positive node or more. So we're going to expand that residual number of lymph nodes, and we are also going to delete that previous oncotype recurrence score require for the 1 to 3 positive lymph nodes responder. It's occurring beautifully, so we're not going to compromise responder, that it's a priority for us. So we're going to allow patients that have positive lymph nodes greater than 1, regardless of oncotype. So that's really going to open the study for many more patients, and hopefully we'll be able to offer them more therapies to improve their chances to remain breast cancer free. So thank you so much for your feedback. It's because of those challenges that you're seeing day to day in the clinic that we're able to adapt our study to make it better designed for the patient. So with this, I want to really thank you for the opportunity to present today.